Welcome, ladies and gentlemen. This is your 15-minute teacher session on diabetic ketoacidosis. Diabetic ketoacidosis is a condition seen increasingly is seen in people with type 1 diabetes, but also increasingly in people with type 2 diabetes. Let's talk about the typical presentation. A 25-year-old gentleman with known type 1 diabetes who has not been feeling well over the past 4 days, with fever and vomiting over the past 2 days and breathlessness over the past 24 hours. On examination, you find that he is quite dehydrated. He's got Kussmaul's respiration, which is a deep sighing respiration. His blood sugar is 28 millimoles per liter, and his chest X-ray shows a right basal pneumonia. All of you will recognize that this is type 1 diabetes with ketoacidosis, and you will all check urine for ketones or a blood for ketones, as well as a blood for pH. As this condition is not dealt with in a standard manner across different hospitals, the Joint British Diabetes Society's inpatient care group produced guidance both in 2010 and subsequently updated in 2013 on the management of type 1 diabetes and ketoacidosis in hospitals. A bit of physiology. Ketone bodies are the product of incomplete fatty acid metabolism. Long chain fatty acids, which contains 20 to 22 carbon atoms, are spliced 2 carbon atoms at a time, and these are released as acetyl-CoA. This occurs predominantly when glucose cannot be metabolized, either as glucose is deficient, as in severe starvation, or when glucose can't enter the cell, as you would see with insulin deficiency. It is important to recognize that acetyl-CoA is burnt via the Krebs cycle. So in a sense, it is fair to say that fats burn in the flame of carbohydrates, and this is an important fact to remember when we delve a little deeper into the treatment of diabetic ketoacidosis. Mr. CH 4 days ago developed an infection, which is why he started noticing rising blood sugars due to increasing stress hormones and insulin resistance. 2 days prior to admission, his cortisol levels rose even further. There was immune activation, vomiting leading to low blood sugars and hence lowered insulin use, and then ketone body formation starts. 24 hours prior to admission, these ketone bodies built up in the blood, leading to ketoacidosis, and the blood pH falls. In order to compensate, the body sends signals for hyperventilation to wash out carbon dioxide and combat acidosis. This, in a sense, is diabetic ketoacidosis, and the body is starving in the midst of plenty. There is a lot of glucose in the blood, which unfortunately cannot enter the cells, and hence the body is resorting to fatty acid metabolism. The pathophysiology is quite interesting. There is fatty acid oxidation, which leads to the formation of acetyl-CoA. This is then metabolized to acetoacetyl-CoA, which then forms the 3 ketone bodies, which are acetoacetate, beta-hydroxybutyrate, and acetone. Acetoacetate is excreted predominantly in the urine, and beta-hydroxybutyric acid is predominantly in the blood. Acetone is exhaled through the lungs and will be the smell that you will pick up as you enter the room of a patient who has diabetic ketoacidosis. The effect of acidosis is considerable. I will not go into any great detail apart from to say that the oxygen dissociation curve is affected predominantly at the level of the tissue, with the oxygen dissociation curve moving in the unfavorable direction at the level of the tissue, leading to further tissue hypoxia, and this can result in further lactic acidosis, which adds on to keto acids that are already present in the blood. Management is, these are the principles of management. Predominantly fluid deficit, the body is dehydrated, and 100 ml per kg deficit is not unusual. This would work out to about 7 liters in a 70 kilogram person. Insulin is required both to burn ketone bodies and also to prevent further ketone body formation. And a typical dose that is required would be 0.1 units per kilogram per hour, which works out to about 7 units per kilogram. 7 units per hour in a 70 kilogram person. It is important to make sure that the blood's ECG and venous gases are checked for pH every 4 hours, particularly as the patient is recovering, in order to ensure that the electrolyte imbalances are minimized, particularly potassium fluctuations. Don't be shy to involve intensive care, as 24 hours on intensive care can do the patient considerable benefit. This certainly beats being on a general ward with very little monitoring, and the patient can come to harm as a result. The typical pattern of hypokalemia is something I would like to emphasize at this point. There is a depression in the ST segment as well as a prolongation of the QT segment on ECG. This will be monitored, this will be recorded as a prolongation of the QT interval, but the actual prolongation is the QU interval, as the U wave becomes very prominent in hypokalemia. The machine will give you a QU reading and record it as a QT prolongation. This is these are the factors that you require to make a diagnosis of diabetic ketoacidosis. Ketonemia of more than 3 millimoles per liter, blood glucose of more than 11 millimoles per liter, and bicarbonate of less than 15 or a pH less than 7.3. One must be aware that ketoacidosis can occur in people with type 2 diabetes as well, particularly in those taking SGLT2 inhibitors, which is a new class of drugs, which I will cover in a different section. Severity of ketoacidosis: blood ketones of more than 6 millimoles per liter, bicarbonate of less than 5, pH of less than 7.1 are all obvious. However, low GCS may signal either intracranial infection or the fact that there is cerebral edema or metabolic disturbances that are profound enough to cause neurological dysfunction. This needs to be recognized promptly, and intubation if required in order to prevent aspiration. Deficits are there on the slide in front of you. Water deficit is about 100 ml per kg. Potassium deficit is 3 to 5 millimoles per kilogram, so make sure that you replace potassium in plenty. Sodium and chloride are also deficient. As you can see there is more sodium deficit compared to chloride deficit. The changes that have been brought about as a result of the new diabetic ketoacidosis guidelines: the first one is that we continue subcutaneous long-acting insulin. Current long-acting insulins have very long half-lives, and it takes a long time for the blood levels to build up if you stop subcut insulin. As this cartoon shows, it takes 5 half-lives for the doses to reach a steady state, and in order to shorten hospital stay, it would be prudent to continue with the subcut insulin while the patient is in hospital with acute ketoacidosis. The second change is the fixed dose insulin that we use, 0.1 units per kilogram per hour. This would equate to about 5 to 7 units per hour. Fixed rate insulin is better than variable rate for 2 reasons. Number one, fixed rate insulin prevents ketone bodies from being formed and secondly, it ensures that there is a good glucose metabolic process going on, and the Krebs cycle is quite active, which will burn up ketones quicker. This is the citric acid cycle, and as you can see, acetyl-CoA enters the citric acid cycle or the Krebs cycle for it to be burnt off. Variable rate insulin that used to be given in the past is no longer being used, as in the past we used to slow down glucose infusion when the blood sugars fell, and this would encourage formation of ketones. On a fixed rate regime, this does not happen. However, close monitoring is required to avoid hypoglycemia. Venous gases rather than arterial gases are currently prescribed, as the pH of arterial versus venous gas is not significantly different. Arterial blood gas is more traumatic, particularly in inexperienced hands, and if you puncture the periosteum, the patient is unlikely to forgive you very soon. Blood ketones rather than urine ketones, as blood ketones are more reliable, and blood ketones fall in a more linear fashion compared to urine ketones, and that is because when we start burning off acetyl-CoA, this equation goes in the reverse direction, and beta-hydroxybutyric acid, which is present in the blood, changes to acetoacetate, which is excreted in the urine. So although ketoacidosis is improving, it might look as though acetoacetate is rising, and this is due to just internal changes in the metabolism of keto acids. Management issues of particular concern are those in the elderly and young patients who are more prone to cerebral edema. People with renal impairment and congestive cardiac failure will need close fluid monitoring. Pregnancy is a particularly challenging time, as you're looking after both the mother and the baby. Fluids to use on a practical setting: normal saline first liter over the first hour, second liter over the next 2 hours, third liter over the next 3 hours, and you might wish to add potassium from the second bag onwards to avoid hypokalemia. Monitor electrolytes every 4 hours and add potassium in the second liter. And always keep the potassium over 3.5, as if the potassium drops below 3.5, this correlates with higher mortality. IV bicarbonate is no longer used and perhaps sometimes more harmful, as it causes intracellular acidosis as carbon dioxide diffuses freely into the cell. There is a theoretical concern of hyperchloremic acidosis with excessive normal saline use. However, practically this is not a major concern. Complications: potassium disturbances, as I mentioned, need a close eye. Hypoglycemia is more common with the fixed rate insulin regime. Cerebral edema occurs in youngsters, and gastroparesis, which can lead to aspiration. Resolution is signaled by a reduction in blood ketones to less than 0.6, a pH which is more than 7.3, blood glucose in the normal range, and the patient ready and able to eat. You can change to subcut insulin at this stage, and it would be prudent to include the diabetes team. Most patients with type 1 diabetes will go onto a basal bolus regime, which the diabetes team can supervise. So it is important to remember that the fixed rate insulin regime is only for the duration of ketoacidosis. If the patient is not ready to take oral food after that episode of ketoacidosis, you may wish to continue with subcut insulin at a variable rate. Before discharge, please go through the precipitating factors that triggered this episode, emphasize 6-day rules, and check injection technique. Precipitating factors can be infection, omission of insulin. The patient's insulin might have expired. There may be the use of insulin omission for weight loss, particularly seen in the teenage and adolescent age group, which you need to be careful about. So in summary, continue subcut long-acting insulin during the patient's admission. Check venous gases rather than blood gases. Check blood ketones. Do not give bicarbonate unless on intensive care. monitor electrolytes every 4 hours, and check for precipitating factors. If you have any queries, please email me. Thank you for your attention.